So good morning, colleagues. My name is Humphrey Ndondo. I'll put my cell phone video for a minute. So my name is Humphrey Ndondo. I am a senior technical advisor for key populations with the Zimbabwe National AIDS Council. I will be chairing today's meeting. I see colleagues are still trickling in on the call. So I beg your indulgence. Let's give them another 2 minutes in case we have colleagues that are a bit delayed, and then we'll start 5 minutes after 2. Thank you. Good afternoon once again. It's 5 minutes after the hour of 2, and I think it's fair for us to start. Welcome to this South to South Learning Network Link and Learn session on integrating mental health in key populations programs. And this Link and Learn session is going to highlight some lessons learned introducing and implementing the integration of mental health for KPs in Zimbabwe, hosted by the National AIDS Council of Zimbabwe and the Ministry of Health and Childcare, and showcasing lessons from the Friendship Bench and SESHA. So we really are interested to know who is on the call. So kindly do introduce yourself on the chat box, write who you are and where you are from. This call has simultaneous translation in Portuguese and in French to benefit our Link and Learn colleagues from Cote d'Ivoire and also from Mozambique and also from Malawi. So we will try and speak with a reduced pace so that we allow for interpretation and translation as we proceed. Just to share a bit as a way of introduction, I've worked at some point as an occupational therapist, providing psychosocial rehabilitation services to general communities and addressing issues related to common mental health disorders and other acute illness, psychiatric illnesses at one of our country's largest institutions that hosts psychiatric disorders. And the biggest frustrations that we have had or that I experienced at that time was really around frustrations with the lack of attention towards mental health as a challenge really for communities. And in Africa, I'm excited today that we are circling back to bring impetus to improving and strengthening, mental health services across the board, because we are realizing that really mental health care services are a priority and a component of well-being that we cannot forego. So our efforts today are to ensure that we are providing mental health care services that are affordable, that are effective and feasible strategies, and that should exist to promote, to protect, and restore mental health for everyone, including key and priority populations. The need for action on mental health is indisputable, and it is urgent today. And urgent so for key populations because historically our communities always experience a disproportionate burden of mental health issues due to challenges with stigma, with discrimination, with pervasive experiences of homophobia, challenges with religion and cultures that do not, or that are rigid and do not speak to the dynamics of a changing context. So mental health is intrinsic and is instrumental and is valuable and is integral to our well-being, and it is determined by a complex interplay of individual social and structural stresses and vulnerabilities. So it is really more important to appreciate that key populations always contend with experiences of heterosexism, experiences of othering and marginalization that make it difficult for them to access services. Today, our colleagues from the Friendship Bench will share some of the problem-solving therapy models that they are implementing to address common mental health disorders, and we will do a deeper dive into how this friendship model has been adapted in Zimbabwe by one of our implementing partners for key populations, SESHA. And we've invited that they share experiences from a peer-to-peer learning model so that we can see what the other countries can learn. And we know that you are doing, you have started doing work also in this area. So we hope to have an interactive platform where we can all share experiences. So without much further ado, I would like to call upon Bernice Chware from Friendship Bench, who is, Bernice Chawira from Friendship Bench, who is going to take us through the first presentation on introduction to the Friendship Bench model. I hope we can all navigate the toolbox to determine where interpretation is. So on your taskbar, you will see something that is circular, that looks like a globe. That is where you will find your interpretation. And you will find English is written there, English, French is written there, French, and Portuguese as PT. So you click the interpretation model that works for you. Bernice, over to you.
Thank you, Humphrey. I'm excited to be here to be talking to you about the Friendship Bench model. Good afternoon, everyone. Hope you are well. So I'm going to talk about the Friendship Bench. My name is Bernice Chawira, and I've been with the Friendship Bench for almost 6 years now. I joined the Friendship Bench through one of the hospitals in Zimbabwe, which is Harare Hospital, when I was working there doing my internship in clinical psychology, which was in 2017. That's where I met Professor Dickson Chibanda, and he invited myself and the other colleagues that we were working with to join Friendship Bench. So it has been an exciting journey for me, and I have been learning a lot through Friendship Bench. So the Friendship Bench started in 2006 in Bare. That's where it started. And in 2006, there was a significant event that happened in Zimbabwe, where there was an operation called the Operation Field, or the Operation Murambachina, as we call it in Shona. So during that time, a lot of illegal structures were demolished because the government wanted to clean up the space. So they were removing illegal structures. So a lot of people lost their houses. Some lost their businesses. I remember during that time, my parents had a small shop in one of the towns called Mufakosi, and it was destroyed, which was one of our sources of incomes. So it caused a lot of distress to people, and it was realized that almost 30% of people who presented at primary healthcare facilities presented with symptoms of depression. So 30% of people who were going to primary healthcare facilities presented with symptoms of depression. So it was because of that Professor Dickson Chibanda started the Friendship Bench. And as he was looking at the available resources or available people who could be trained and offer the intervention at the clinics, the nurses were busy with a lot of work at the clinics. The doctors were busy. The only available resource were the grandmothers. So that's when he trained grandmothers on how to sit on a park bench and offer the problem-solving therapy. That's how it started. So it's just a brief psychological intervention, which is delivered by trained community grandmothers. So that's how it started. And as years went by, we noticed that there was also a need for us to train young people, because usually people who go to primary healthcare facilities, you notice that most of them are women. And we noticed that from our statistics, 80% of people who were sitting on the bench with grandmothers were females. The reason why it's like that is because most of the times women are at the clinics, maybe with their babies, for vaccinations, for weighing, for the care of the babies. And sometimes when the babies get ill, it's the women who take babies to the clinics, and also for their prenatal care. So usually antenatal care, sorry, when during the time of pregnancy, they go there for care. So that's why 80% of the clients that were being seen are women. And we also noticed that there is need for us to take this intervention to the communities. So it was not only in the clinics where the intervention was just being provided. The intervention also went into the communities, and now parts of the intervention is being delivered in the communities. And we also realized that there's also a certain population that is being left out. We trained young people in universities. We trained young people in the communities to also offer the intervention. And also we realized there are some people who are not comfortable to sit on the bench with a grandmother. They are comfortable to be online and have someone talk to them online. We also expanded our services to online. So basically, this brief intervention is now being offered in primary healthcare facilities, at community level, and also online. So can we move to the next slide? So some may want to ask, why grandmothers? I once said grandmothers were the available resource when the intervention started in Bari. And culturally, grandmothers are seen as the go-to people. We notice in our culture, when people have got problems, they look for a grandmother or gogo to speak to when they are having challenges in their lives. It could be marital, it could be any problem which you feel that if you sit down with an elderly person, they can assist. So culturally, grandmothers are accepted and they are the beacon of wisdom in families. So it became so easy for people in communities to approach grandmothers with problems. That's why we also trained grandmothers to offer the intervention. So as Friendship Bench, we are big on research, on evidence. One of our values is we are anchored in research. So there was publication in RCT, a randomized control trial that happened in 2016. So this randomized trial showed us that grandmothers were the best in offering this intervention in reducing symptoms of depression when they sat on the bench with the client and helped them through their problems. So as these grandmothers do the problem-solving therapy, it's not only about sitting down with the client, helping them through their problems, but it's also a process of empowerment where the grandmothers empower the client with a skill to solve their own problems in life. So we expect a client to do maybe up to 6 sessions or less with a grandmother. But after that, we also expect them to have a skill that they can use to solve their own problems in life. Can we go to the next slide? So the Friendship Bench intervention is also being replicated in 10 other countries. So it has worked so well in Zimbabwe. We've scaled up to all the 10 provinces in Zimbabwe. We are now in all the 10 provinces, and we are looking forward to expand to all areas, because as Friendship Bench, our mission is to get people out of depression. And as we get people out of depression, our aim is that we cover all places and no one is left behind. Hence, our vision is to have a Friendship Bench within walking distance for all. So we would want our services to be accessible to anyone in any place, be it in the rural areas, be it in the urban areas, in the peri-urban areas. We just want people to be able to receive this service even online, wherever they are. And our values are empathy, connection, anchored in research. So we teach our grandmothers to be empathetic. We talk about empathy even here at Friendship Bench with the Friendship Bench staff. We want to practice empathy because we've seen that with empathy alone, people can recover from mild to moderate cases of depression. And we also talk about connection. We would want our delivering agents to connect with clients as they sit on the bench, as they have a discussion, as they guide them through solving their own problems. We would want them to have that connection. And also research. We are big on research. Everything that we have done so far is evidence-based. There are so many publications that have been done through the Friendship Bench that show the kind of work that we are doing and the impact that we are making. So as the Friendship Bench, we've got a training model that we have. We start with training of trainings, where we identify grandmothers that we can train through the Ministry of Health. And once they've been identified, they are trained as trainers. After they've been trained as trainers, they are also expected to go and train grandmothers in the communities. After they've trained grandmothers in the communities, each grandmother is allocated a park bench where they offer the intervention to clients in the communities, be it in the communities or in the primary health care facilities. And each grandmother, after they've been allocated a park bench, they are also expected to receive support from supervisors. So there will be supervisors who also offer support. This is also to ensure that they offer good services. They offer services of good quality to clients. So that's how the training model works. And Friendship Bench prioritizes partnerships. We have partnered with the Ministry of Health. That's where we get some of the grandmothers that we train. Also had partnerships with organizations like SESHA, who are doers of care. So we've partnered with organizations like SESHA. SESHA is one of the big organizations who has been running with the intervention, taking people out of depression through the intervention by touching the area of key populations. So SESHA has done that so well. And as Friendship Bench, some might want to ask, can we go to the next slide? How we measure success. So we've got a lot of indicators that help us to measure success. I'll touch that in the next slide. So these are some of the services that we offer as Friendship Bench. We offer training. We offer talk therapy through benches. We also have a component of support groups, which we call the Seko Kubatana Tose or CKT, where we expect our clients to join support groups. They discuss about problems that they'll be facing. They talk about the ways that they manage to solve those problems. Remember when I spoke about the work that a grandmother does on a bench, which is not only limited to talk therapy, but also giving a skill to clients. We want clients to talk about the skills that they would have gained from the grandmother as the grandmother guides them on problem-solving therapy. So we also do the youth program where we've trained youth to offer the Friendship Bench intervention to their peers. And also partners, they fall under this arm as well, where we train different cadres that we get from partners, be it key populations. They are trained and they also offer this intervention to their peers. And we also have a component of research. I spoke about the randomized control trial, which was done for the Friendship Bench and other publications. And as a Friendship Bench, we also do sensitizations and awareness in the workplace. So we noticed that, yes, we are there in the primary healthcare clinics. We are there in the community. We are there on the online space. We are offering this intervention to young people. We've managed to tap in the space of key populations. But there was one area that we also noticed that was being left behind, which is the workplace. And we managed to get through that space, and we offer usually sensitizations and awareness in the workplace. So these are some of the services that are offered at the Friendship Bench. Next slide. So impact to date. So far at the Friendship Bench, we've managed to train over 2,500 community health workers who have been trained to offer the intervention in the community. We've also managed to reach over 560,000 clients through our intervention. And we've also managed to have over 400 support groups of clients who've received the Friendship Bench intervention on a bench with a grandmother. And we are in over 6 countries where the Friendship Bench has been replicated. And we've noticed a 78% reduction in suicide ideation and a 60% improvement in quality of life of our clients. Then that goes to, how do we measure success, or how do we track what we've been doing so far? So these are some of the indicators we have been tracking. We have been looking at the reach of clients, like what I said. We've also been tracking, and we continue to track on the amount of grandmothers trained in different areas, and also counseling sessions that are being done or that have been done. We also look at the percentage of the reduction score of the SSQ. So when a client starts having sessions on the bench, we would also want to see if there's a reduction in their SSQ score. So after a number of sessions, we contact clients, and we would want to see their baseline score compared to where they are now. So we compare all those, and we also look at the number of clients who are in support groups and the number of groups that have been held. And we also look at the number of suicides averted. So these are some of the things that the indicators that we track as we implement as Friendship Bench. And this speaks to our mission and our vision, which is to make sure everyone gets access to the Friendship Bench intervention, and at the same time getting people out of depression. So over these 10 years, we have seen an improvement in the quality of life of the people who have access services at the Friendship Bench. Next slide, please.
Thanks, Bernice, for that presentation. We have a video that we want to share. I don't know if colleagues can cue the video in. At the end of this video, we are going to ask our colleagues who are translating into French and also into Portuguese to give us some brief summaries really of a descriptor of the video that we're showing. If you can go ahead, please.
Sometime 2013 ndo pandakatanga kukosora, kuita mudumbu, chaya, until ndatozosvika pastage yekuti ndakasvika pakurwara kuti ndaisikachagona kumuka, ndikatakurwa kuenda kuhospital kuNazareth. Ndasvika kuhospital ndakadiagoniwa ndine TB, and ndopandakabva ndatestwa ndikaonekwa ndiri positive. Ndagara muhospital at least for 3 months ndisingagone kumuka, ndisingagone kuita sei, and mhuri yanga isingachakwanisi kuwana chekudya uye pekugara paya pakunetsa because tinoloja. Saka pakanga pane dambudziko rokuti pressure yanga yandiwandira kumba nemudzimai, zvokusvika pastage yokuti takatopedzisira taendesana kumakotsi and everything. At one stage ndaitomborara mumabridge because kumba kwai kusingacharariki, kwai kwakutopisa zvokuti hapana zvandaikwanisa kunyengerera.
264 million people suffer from depression globally, and close to 800,000 people die due to suicide every year. That's one suicide every 40 seconds.
Zvinhu zvasina kumira zvakanaka, taigara tichinetsana mumba, even mari asingazive kuti ndinodawo kurarama mumba, achiita musikanzwa, musina kana communication mumba, nokuti pfungwa dzandinadzo ndatofunga zvokutokomita suicide.
76% to 85% of people in under-resourced settings who need treatment do not get or cannot access care. In my native country of Zimbabwe, with a population of 13 million people, there are 12 psychiatrists, meaning that theoretically, one psychiatrist would serve over 1 million people. This is not a practical solution for mental health, but unfortunately, we don't have enough health professionals and facilities to do the job.
After considerable consultation and soul-searching, talking to colleagues, friends, and family, it suddenly dawned on me that actually one of the most reliable resources we have in Africa are grandmothers. Yes, grandmothers. And I thought, grandmothers are in every community. There are hundreds of them. And they don't leave their communities in search of greener pastures. See, the only time they leave is when they go to a greener pasture called heaven. So I thought, how about training grandmothers in evidence-based talk therapy, which they can deliver on a bench, empower them with the skills to listen, to show empathy, all of that rooted in cognitive behavioral therapy, empower them with the skills to provide behavior activation, activity scheduling, and support them using digital technology.
We have trained over 700 grandmothers or lay health workers and seen more than 70,000 clients. We are active in 5 countries: Zimbabwe, Malawi, Zanzibar, Kenya, and New York City.
Ndasingachaziva chinokwanisa kundibatsira ndechipi, ndakangomanikidzwa ndikapesera ndauya pano. Noti kumanikidzwa nemunhu, but pfungwa dzangu ndo dzakundinetsa because ndaenda kutombofunga kukomita kuzviuraya because ndandisina pokugara, and situation was yanga iri out of hand. Taura chokwadi. Ndobva ndauya panapa ndopandakazonzwa pane program iri kuitwa yebench reushamwari. Ndaiuya pano almost every week ndichatenda masessions aitwa pana ndichikanselewa, and ndauya panapa ndakatozodiscover kuti handisiri ndega ndine problem iyo, takawanda tine maproblems akadaro. To those people vataiinteracta navo panapa kandofunga vanogona kundipupurira kuti mwiri wake wanga usina kuita zvawakaita izvi. Ndakagainya strength each and every day, self-confidence, strength yokuti handisati ndafa ndichiri mupenyu ndindogona kurarama for long time, as long ndine self-confidence yekuziva kuti kurwara doesn't mean kuti ndatopera, nenyaya yekuti ndakaenda wana dzidziso yakasimba kubva kunana mbuya vanga vari pana. Ndikatanga kutsvaga zvaindibatsira kuti ndikwanise kurarama. tanga kutengesa kubika zvimwe zvimabhanzi zvaninobika nchitengesa nchidi up to now ndo zvakutondisurvive and even kumba relationship iri kuimprove almost every day.
Our goal over the next 5 years is to see 5 million people. And how we plan to get there is by training 15,000 grandmothers or lay health workers and expanding our services to 10 countries. Our vision is a friendship bench within walking distance for all.
Thank you so much, Friendship Bench. So thanks a lot to our Friendship Bench colleagues. We will have a brief question and answer to speak to if colleagues have any areas they want to clarify, if they have any questions, or you wish to follow up on any issues that came up out of this video. I think very compelling statistics there, one suicide every 40 seconds, and a very, big, huge gap of service provision, one psychiatrist really per roughly 1 million people in Zimbabwe with the population of 13 million. If you considered that if we were really to be put on a scale that screened us for common mental disorders, a lot of us would be very borderline. But I would like to open this floor for discussion and for any questions and answer from the floor. I'm seeing 2 questions. I'll take Anis, Mita, and Anis. Let's start with Anis and then come to Ida, and then Dominic. We'll take these first 3 hands and then take another round after this. Over to you, Anis.
Thank you so much. I didn't get your name, but thank you so much to the presenter for this beautiful presentation, and also to congratulate you for this good initiative. But then also I wanted to find out, considering that we are using grandmothers, and these are the people that are found in our communities where also this key population are found. I don't know if I missed that part, that this initiative is also including the key populations. But then if you talk about key population, we're also talking about men who have sex with men. So how is it like for these grandmothers when they're meeting these MSM in their communities? Are they not associated to being promoting homosexuality in their communities? And if so, what are the measures that are put in place if anything happens to these grandmothers, if maybe they are attacked or something? Or what are the challenges that they've been facing? I just want to find out what are some of the challenges that they've been facing from their communities when they're providing these services to key population, especially the MSM. Thank you.
Thanks, Anis. Ida?
Hi, good afternoon. Thank you so much, Friendship Bench and Sesha, for the great work that you are doing in terms of provision of mental health services. I think I have an almost similar question with the previous speaker was asking, in terms of providing mental health services, have you found something different? Is there something specifically unique, like in terms of differentiation of services when you provide mental health services for key populations in other GenPop? Thank you, and over.
Thank you, Ida. Dominic?
Yeah, thank you very much for the presentation. It's a very interesting service delivery model. And I'm hearing for the first time that it's also implemented here in Malawi. Yeah, but anyway, I wanted to follow up now on the age category. From what age do we consider them grandmothers and those that we recruit? And also the experience like in Malawi that most of the grandmothers, their literacy levels are very low. I know the situation might be different in Zimbabwe, I don't know that how impacts the program itself. And also from the video, there was also a mention of use of digital technology. And from experience, grandmothers are not really very good at technology. So how does that work? Yeah, thanks, and over.
Thanks, Dominic. Thanks, Anis and Ida, for those questions. Can I ask Dennis to come through and respond to these three, and then we'll take another round of 3 questions.
Thank you for the questions. So for the
Also, Dennis, if you can speak a bit louder and closer to the mic, I think you're faint on my end.
all right, can you hear me now?
Let's try.
All right, thank you for the questions. So for the first 2 questions that we're asking about grandmothers offering services to key populations, we also noticed that most of key populations were not really going to grandmothers for mental health services because of the issues to do with stigma, and some grandmothers don't really have an appreciation of how they can give the intervention to key populations. So that's why we ended up having a partnership with SESHA, so that we don't leave anyone behind when it comes to mental health services. So for us, having the intervention being offered also by key populations also assisted in getting more people to access the service. And also the second thing was sensitization of grandmothers on key populations. This was one of the things that we did here at Friendship Bench, just to educate grandmothers of what it means for someone to be part of the key populations and how to treat key populations when they come to get service from the Friendship Bench, and also how to refer. So sometimes a grandmother may not feel comfortable. They can refer, and some of these services are in clinics where the grandmothers are working. So they know that if I get maybe someone from the key populations, I refer to the SESHA clinic, because some of these services are in the clinics that the grandmothers are in. So yeah, that's it. And I cannot talk much about the challenges that grandmothers have been facing when offering these services, because some of them have actually been referring if they get any people who reach out who are key populations. But we've noticed that most people under the key populations group, they haven't been really seeking for these services from grandmothers. That's why we had to have a partnership with SESHA, because we know that at SESHA, that's where most key populations go, and they know that they can get services at SESHA. Then when it comes to the age of recruitment, we would want any grandmother who can read or write. So there's really no age limit when it comes to grandmothers who can offer the service, as long as they can read and write. And most of them that we train are already under the Ministry of Health. So some come to us as referrals from the Ministry of Health. So yeah, if any grandmother can read or write, they can be recruited in the program. And if they feel that they can still work, they can still be trained and offer the intervention as recommended by the Ministry of Health, we take them on board. I don't know if I've answered the questions fully.
Thanks, Bernice. We also have 2 questions online. One is asking about whether we train the grandmothers in English or they are trained in a vernacular language, and what the specific challenges related to modality of trainings is, particularly as it relates to language. And secondly, a second question was about whether the the training material is adapted for the needs of young persons or of youth. Looking at, is the messaging also developed in an age-appropriate manner, considering the different age ranges when we talk about or when we refer to youth? Those two, and we'll take the last three from.
Thank you for those. I also realized I didn't answer the question on digital technology. So yeah, I'll answer that. So when it comes to the youth, yes, there was a study that was done. It must be in 2020, where the intervention was adapted for the youth. So yes, information is disseminated to the youth in the way that they understand, or in the way that is relevant to the youth. So there's also what we call the Youth Friendship Bench, which is led by a youth. The leader is part of the youth, and they disseminate information as according to the needs of the youth. They've got presence on social media platforms, different social media platforms, where they post information that is relevant or that relates to the youth. Then also the other question on digital technology, our grandmothers have been, we've been in the process of training them on data capturing for the clients that they would have seen in the clinics, and it has been going on well, with a few challenges on some of the grandmothers. But yes, we've successfully trained grandmothers on how to enter data using mobile phones, and it has been working for most of the provinces here in Zimbabwe. What was the other question?
The language for training.
Oh yes, language for training. We do trainings for grandmothers in the local language. So if it's in a place where they speak Ndebele, training is done in Ndebele, and resources are in Ndebele. The screening tools are in Ndebele. The other tools that grandmothers use are in the local language. And if it's Shona, they are also trained in Shona. The tools are also in the local language. So yes, trainings and tools are in different languages.
Great. So there is more questions coming on the chat. One question relates to an inquiry on whether the friendship bench is in Malawi indeed. And I think this begs for a link and a connection to friendship bench in Malawi. I think there's interest in ensuring that we create facility or linkages between friendship bench Malawi and colleagues that are on this call that could be interested in doing this work. We will take just these last two questions and move directly into the presentation from Sesha, and then you can respond to this on the chat.
Okay, so can I just give a quick response on the Malawi question? Yes, friendship bench it was piloted under the UNC. So UNC Malawi piloted the intervention in Malawi. So yes, it's in Malawi under the UNC project. That's when it was piloted, and it was being done in different studies where they incorporated the friendship bench intervention in different studies. Some of the studies were studies done on NCDs. Some of the studies were studies done on pregnant women. A lot of studies that have been done under UNC, some of them were used in the friendship bench intervention.
Great. Thanks, Penny. So thanks a lot, friendship bench. Without much further ado, can I kindly ask colleagues that have their hands up to share their questions on the chat, and ask Bernice that you stay on the call, Bernice, and respond to the questions that are coming to you, and let's have an interactive chat discussion. I would like to give over this opportunity to our colleagues that are leading our presentation. from SESHA's Stembile Msemburi. Over to you, Stembile.
Thank you very much, Humphrey. Please confirm you can hear me.
Yes, loud and clear.
Thank you. Good afternoon, colleagues. My name is Stembile Msemburi from SESHA, and we are going to present on mental health integration into HIV prevention programming among key populations in Zimbabwe. And I'm going to be co-presenting with Matilda Mawere, who is a friendship bench buddy within the KP program. Next slide, please. Next slide. So evidence from RDS surveys that were conducted by SESHA between 2016 and 17 showed that there was high prevalence of common mental health disorders among sex workers, which was from as low as 41% and as high as 48%. And then this necessitated the need. Sorry, can you go to the previous slide?
We can proceed, Stembile. We are on your background slide.
All right. So this, as a result, SESHA saw the need to integrate mental health services within the KP program, and this was to be done through partnering with our friendship bench model. So as Bernice has explained in detail what the friendship bench model entails, this was about training lay health counselors for a sustainable community-based psychological intervention. We partnered with the friendship bench project in 2019, supported by USAID, and this was a pilot project that was done in Harare. And then we scaled up to Bulawayo in 2020, Mutare in 2021, Mashingo and Gwere in 2023. As Bernice mentioned earlier on, we appreciate and know that the needs of key population is different from that of the general population. As much as we adopted the need, there was need to then adapt it to the needs of the key populations. So SESHA then had peer key populations who were trained as friendship bench buddies to be service providers. And these were supported by supervisors from the friendship bench. Next slide, please. Sorry, Humphrey, the slides are not moving from my end. I'm not sure if it's my... So I'm not going to dwell much on this slide because Bernice went through it. There is evidence that friendship bench model works, as shown from the article that was written by Chibanda et al. Of the randomized clinical trial. As such, SESHA then went on to adopt it for the K populations program. Next slide, please. The following steps were taken to adopt the friendship bench model for key populations. First, there was formative work, which was done through a workshop for theory of change, where the community was engaged and they were part of the design of how they wanted the program to be implemented within the service points where they access services at SESHA. And we also engaged community-based organizations that work with the different key populations for them to help us mobilize and identify potential friendship bench buddies. These were then trained to be service providers and got technical support from friendship bench. To date, since 2020, SESHA has had 52 key populations through friendship bench trained as lay mental health counselors in the 5 districts that I mentioned below. And of these, 40 are female sex workers, 10 are transgender, and 2 are MSMs. SOPs were also developed to help and guide the lay mental health counselors on how they're supposed to carry out the counseling and also make sure that the quality of the service that they offer to their peers is of high quality. There was need to also adopt to the changing environment, mostly during COVID-19. This is what brought then about the differentiated service delivery model, where we had to go beyond just accessing services from the facilities, but also offer online counseling through either telephone or WhatsApp groups that the Friendship Bench Buddies also then created. Sorry, with the WhatsApp platforms, not the WhatsApp groups, sorry. These digital interventions were meant to extend the reach of health services to the key populations. Next slide. So I'm now going to hand over to Matilda so that she can take us through the KP-led case finding and support that they do as Friendship Bench Buddies within the KP program at Sesha. Over to you, Matilda.
Thank you. Afternoon. I am Matilda Mawere. I am a Friendship Bench Buddy. We were trained in 2019. 2020, we were trained for online training. Then we are working in community facility and in the drop-in center and also online. Then we have a tool. We used to screen our patients. That is the screening for common mental disorders. After we screen, if you reach 8 and above, 8 and below, there is no further management needed. And it is 8 and above, we have to give you sessions, to deliver you sessions per person or online. If it is when our SSQ, that is 14 questions, we screen for you. If it is 5 and 11 question, 5 and question 11, that is the red flag, that is suicidal patient. So we refer out to the nurse counselors. And 8 and above, we do online with sessions for up to 4 sessions. That is 4 sessions. It's an advantage to people who have been given appointment from the clinic, that we will do 4 sessions. If not so, some people cannot have WhatsApp or whatsoever to reach them. So if our Friendship Bench Buddies, we are doing our supervisions from Friendship Bench once every month to supervise us from what we are, our challenges. So from 2019 up to now, we are seeing that our sessions are improving our training from day 1 up to now. So this is the advantage for what we have trained. Thank you.
Thank you very much, Matilda. So here, I think Matilda was just explaining how they work as Friendship Bench Buddies, where the services are accessed, and the kind of screening that they do for their peers to try and identify for common mental health disorders, and for those that have red flags who are then referred for further management, and how they also get support from the Friendship Bench Project, supervision support from the Friendship Bench Project on a monthly basis. Next slide, please. So since the program inception in 2019, you will see that there has been an increase in the uptake of the Friendship Bench services, as shown on the graph that you are seeing on your screen there, where in 2023, we have more than 5,000 key populations accessing services. And then in 2019, it was just below 1,000. And to date, we've had more than 12,000 persons accessing mental health services through the key populations Friendship Bench, with 40% of them being younger than 25 years of age. Our service entry points also differs by year. You'll find that in 2021, where there was COVID, we had a peak in the number of people who accessed online services, with 15% of them accessing services online due to restrictions, travel restrictions, because of COVID. However, when those were lifted, you find that the access of services at facility level or at the clinic then also increased. The availability of the differentiated service model has ensured that KPs are able to access services at a place of their convenience. So you'll find that about 1/3 of the sessions were still accessed outside of facilities, even though we no longer have the COVID restrictions. We still have some opting for online. We still have some opting to access services in the community. And disaggregating our data by gender or key population type, you will know that 90% of the key populations that have access services at our clinics or at through the friendship bench bodies within the KP program are female sex workers. Next slide, please. This slide here shows the SSQs at first assessment, like Matilda alluded to. At first assessment, an SSQ 14 tool is used, right, to assess if this person needs further management or not, to also determine if they have red flags and they need to be referred to our qualified and trained nurse counselors and not the lay counselors. So you'll find that between 2020 and 2023, 41% had a score below 8, meaning that they did not need further management. However, 59% of the core populations that were seen had a score that was greater than 8, meaning that they needed to be assessed and also go through the 4 sessions that are recommended. And during the assessments, we noted that intimate partner violence and stigma are still common complaints from the key populations, and these actually have potential barriers to engagement and continuity in clinical services. We also noted that gap remains in quantification of substance use, the prevalence of quantification of substance use among key populations. Next slide, please. Next slide, please. In the years that we've been implementing the friendship bench model from 2019 to date, there are lessons that we've learned. And one of the key lessons we learned as a KP program is that KPs prefer KP-led friendship bench to other models. This was informed during the formative work, and this actually informed the design of the program that we implement as SESHA, where the KPs themselves were able to design and say who should be on the bench and where the bench should be located. Was it supposed to be located at the facilities? Were we supposed to have grandmothers sit on the bench? It was the KPs who informed the model that we're going to adopt and implement as the KP program. And as a result, you'll find that the uptake of the services has been quite high, with more than 12,000 key populations being reached since 2020. We also noted that it's important to collaborate with community-based organizations who work and represent KPs in the community, as they know the community and they are able to help you identify ideal people who have the capacity to be lay counselors within the community. And as a result, like I mentioned before, we have diverse representation in our French bench bodies. Although majority are still female sex workers, we have 10 transgender and 2 MSMs. We also noted that there's a need to adopt, where we now have differentiated service delivery. The services are not only accessed at the facilities, but one can access the services in the community, at the DIC, or online, where it's convenient for them. And this also improved the uptake of services, which, with these differentiated service models, contributing to about 1/3 of the sessions that were accessed by the program in the first 4 years of implementation. This brings me to the end of my presentation. I'll hand over to Humphrey. Thank you, and over.
Thank you, Stembile, for that presentation. And thanks a lot to your colleague, Matilda, for sharing the roadmap that they use within implementing and navigating communities through a friendship, KP friendship body system. I would like to open the floor for discussion. I think we had quite a number of questions that were inquiring what this adaptation of the general friendship bench looks like for key populations. And as Stembile is advising that from the years that they have implemented this program since 2019, they are realizing that KP would prefer that their peers are the ones that are the providers of the screening of mental for common mental health disorders and providing the first line therapies and referral for other care. So this is open for discussions. I think let's ask more difficult questions while we still have Stembile and Penis. I think it's Rabe, R-A-B-E. Your hand has been up. I think you have an opportunity. Let's take it away. Over to you.
Oh, merci. Je suis docteur Abbé. Allô? Allô, bonjour. Bonjour. Est-ce que vous m'entendez?
Wonderful. Over to you.
Est-ce que vous m'entendez? Je vous appelle de la Côte d'Ivoire et j'ai vraiment aimé votre exposé. C'est vraiment original. Mais ce que je veux dire, est-ce que les friendship banks, est-ce que sont-ils comparables aux DIC ou bien ce sont des structures privées qui sont structurées et puis organisées par les populations clés eux-mêmes? Et puis ensuite, le contenu des services, est-ce que c'est surtout des services à l'endroit? Parce que votre thème, c'est la santé mentale. Je voudrais savoir si c'est spécifiquement la santé mentale et quel est le contenu de la formation que vous administrez dans ces friendships, parce que en santé mentale, il y a le contenu de ce que vous administrez ou bien vous donnez à ces populations clés-là, afin qu'eux-mêmes soient des formateurs et qu'ils puissent véhiculer, puissent encadrer leurs pairs qui sont dans des situations de dépression et de suicide. Et si tel est le cas, je voudrais que vraiment vous venez soutenir aussi la Côte d'Ivoire parce qu'on en a besoin. C'est vrai qu'il y a un programme national de santé mentale qui existe, qui travaille bien, mais ils ne sont pas nombreux. Et les populations clés, il y a beaucoup d'organisations en Côte d'Ivoire. Donc, il serait souhaitable que le premier exposé là, que vous avez fait était très original avec les grands-mères. Je voudrais qu'on puisse aussi l'implémenter ici en Côte d'Ivoire. Je vous remercie.
Thanks, Dr. Rabi. I will take another hand from Pari.
Thank you so much. This is a wonderful presentation by both Friendship Bench and Sesher. I think the message that I'm taking from Friendship Bench is not so much the bench, but more the involvement of lay counselors to do initial screening, talk therapy, and then the most difficult mental health issues or cases then go to specialized services. And I really like the presentation of adaptation of the same concept in a KP program. So my questions are to actually Sesher. And first of all, thank you so much for sharing that you have a SOP. It will be fabulous if you give us a link to the SOP so that we can put it up in the SSLN website, but also everybody can access it. My questions are your Friendship Bench buddies, are they different from peer educators and your microplanners? Or do you select some of the peer educators to become and train them and they become the buddies? So that is one of it. Do you pay these peer educators extra amount for doing mental health? That is my second question. And my third question that I saw was, you had a lot of FSWs who were trained, but very few MSM and transgender. Is that reflection of the community that you serve, or is it because it was a pilot or whatever, but in the scale-up phase, you will actually engage more MSMs? And what was the difference? Is there a difference between how you provide services to FSW, and you provide services to MSM. Thank you.
Great. So those are very great questions, and quite a number. So I'll invite Bernice to come through first and address Dr. Rabe's questions, and also Stabile to speak to the questions that Patty just asked. Over to you, colleagues. Bernice?
Oh, sorry, I didn't get the question that I'm supposed to answer. I thought they were questions for Stembile.
So the questions from Dr. Rabe were asking how Friendship Bench is structured. Is it a government entity? Is it a private entity? How is it working? What is the kind of training that you are providing to the grandmothers? Because there is a minimum package that you need to provide to lay providers to be able to screen and then refer people with common mental health care disorders into. So what does that look like in terms of, are you a private model? Is this scalable with the government, etc.?
Okay, thank you for that. So we started as a research entity. Our focus was mainly on research, and we moved from research to implementation as a private organization. But when we started doing research, it was in collaboration with the Ministry of Health. And as we were implementing, it was also in collaboration with the Ministry of Health, because most of these grandmothers that we've been training, we get them from the Ministry of Health. So these are grandmothers who are into health promotion under the Ministry of Health. So we also train them on the Friendship Bench component so that they can offer mental health services in communities and in clinics. So now we are a registered PVO. We are now moving into handing over the intervention to the Ministry of Health. So yeah, that's where we are. And we've had a very strong partnership with the Ministry of Health, because most of our services are being offered in clinics which are under the Ministry of Health. And the Ministry of Health is the one that gives us authorizations to work in their clinics and even in the communities. So we are in the process of handing over the intervention to the Ministry of Health. And this is scalable. We've scaled to all the 10 provinces in Zimbabwe and also in other countries. And we train grandmothers on the intervention. We train them on how to screen for if one is at risk of having depression or not. So the tool that we use for assessments is not a diagnostic tool. So our grandmothers don't diagnose if one is depression or not, but they just screen for the risk of having depression. And they are trained, there's an 8-day training, which our grandmothers go through. And it consists of content and practice. So most of the work that happens during the training is mostly practice. And assessments are done. The grandmothers go through a 1-month internship before they can actually offer the service to clients. So there are a lot of checks before one can see clients. And our training is in different levels. So there's level 1, level 2, and level 3. So depending on the needs of the participants, some participants may just want level 1 training. Some participants may want level 1 and level 2. Some may want level 1 up to level 3. But we cannot train you level 2 if you don't have training for level 1. So our training is in 3 levels, and people can be trained on any of the levels, but you have to start from level 1, depending on your needs.
Thanks, Venice. Maybe let's move to Stembile and to
Thank you very
respond to
much.
questions from Pari.
Thank you very much for the question. So the first one was a suggestion or a request for us to share the SOP. We've noted that the SOP will be shared. And then the first question was, are the French bench bodies different from the microplan and peer educators? Yes, they are a different cadre within the KP program. These are specifically meant to handle the counseling, the mental health issues, and they are different and separate from the operations of the microplan and peer educators. Do we pay? These are volunteers. We do give them allowances, but they are volunteers. So yeah, they do get an allowance, but they are volunteers. And then you noted that we've got more female sex workers in our data. Yes, so you'll find that initially when the SESHA program started, it was servicing female sex workers, and then we specified to include key populations in their diversity. I think should be in 2019, if I'm not mistaken. So you'll find that even the KPs that we serve, female sex workers contribute 90% of the key populations that we serve. So we are still, we're still growing in the area of reaching to more transgender and MSMs.
Yeah.
I think those are the
Thanks,
three questions.
and colleagues are asking on the chat if we are providing these services to prisoners and to people who use and inject drugs. Unfortunately, our national program for people who use and inject drugs is just being introduced. So we will be exploring all these DSD approaches to be extended to serve these additional our KP profile. At this point, we are still cleaning these lessons from the FSW and MSM programs and trans and gender diverse persons programs, and hoping in this very near future, we will be able to bring this to scale through human-centered design approaches to serve other communities of people who inject drugs and prisoners. Any more hands? Any more questions? Seeing any hands, any follow-ups? Should I take it that we are all understood? I see a hand from Lambda. And also Pari.
Hello, can I?
Yes, Roberto, go through, please.
Bom, muito obrigado pela oportunidade. Meu nome é Roberto Paulo, da Lambda em Moçambique. Obrigado pela apresentação. Eu deixei uma questão no chat, mas se calhar por conta da língua, pode ser que passou despercebido. Queria saber se nesta abordagem eu entendi que treinam as avós, mas considerando organizações que, por exemplo, têm programas que implementam usando a estratégia de educação de pares, onde o educador de par é o ponto de contacto para com os beneficiários. Queria saber se há alguma possibilidade de, por exemplo, capacitar estes educadores de pares para que eles façam um rastreio de beneficiários que precisam de apoio em termos de saúde mental, para depois referir a especialistas que se calhar ofereçam o atendimento um pouco mais profissional e profundo. Digo isto porque, bom, na situação atual, o educador de par portanto, é o nosso embaixador, passa a expressão, é a pessoa que tem o primeiro contato com os beneficiários. Então, a minha dúvida era esta, se há como dotar este educador de par de pequenas técnicas para que ele possa apenas fazer o rastreio e, dependendo do caso, depois fazermos a referência. E também queria saber em que países estão a implementar este programa e se países como Moçambique, por exemplo, tiverem algum interesse, como é que eventualmente podem ser incluídos, havendo espaço. Obrigado.
Thanks, Robert. I think that goes to you, Stembile. Is the opportunities of integrating or layering the training for the screening for common mental health disorders or depression within the peer educator footprint, such that it is not a separate cadre as we have in Zimbabwe. Would that level of effort, is it possible to layer the level of effort for screening for mental health disorders in this friendship bench model for peer educators? A request for who, where else is this program being provided? If they were interested in to start a program, who can they work with?
All right. Thank you very much,
Ari?
Humphrey. So should I
Please
respond?
proceed.
All right, thank you very much. So within the KP program, what we did is we separated microplanning and the friendship bench buddies. I think solely because you find that with the microplanner, they do have differentiated service delivery for their peers that they are microplanning. But you'll find that when it comes to mental health issues, someone might not be comfortable to go to their microplanner and disclose what's going on with them. So they'll rather go to a bench at a facility or online, just get a number of somebody that doesn't even know them in person, and then maybe they talk freely with that person, than they would with somebody who's constantly microplanning them or in touch with them. So I think for issues to do with confidentiality and also to encourage seeking the mental health services, I think we saw that there's a need for us to separate the two cadres. We do have microplanners who are trained in the friendship bench buddies, but they're to choose between the two because you cannot be both within the KP program. So we have microplanners who were trained, who became friendship bench buddies, but then they had to drop from being microplanners because we wanted to separate those two streams of work. And then currently we are operating in Zimbabwe, and yeah, we do not have beyond. So SESHA is operating in Zimbabwe currently. I hope I've responded to the question.
Thanks, Tembile Pari. If you could come in, yes, please.
Yeah, I have more nitty-gritty questions, but Bernice or anybody can share. I want to know how long is the training? So when you train peer educators as buddies, how long is the training? And what kind of mentorship is provided? Like after the training, can the buddies go on their own and do their work? Or is there some mentorship and support that is provided for the buddies to do the mental health work? Because mental health work is also difficult and challenging. Like peer navigators, we have also heard many times that key populations or sex workers or MSM do not want to go to peer educators to share some of their problems. Have you had such cases where they do not want to go to peer educators? They need non-community members as buddies or support for mental health. And then what happens? Thanks, Humphrey.
Stembile, do you want to come back, or Bernice, do you want to come in?
I'll answer the first part of the question. So thank you for that question. So we offer 8 days training, but our training is split into levels. So it depends with which level that you want. But if one wants to be trained to offer the whole problem-solving therapy on a bench, they have to go through the 8 days training. And after they go through the 8 days training, they do a 1-month internship where they continue practicing, and we assess after that 1-month internship if they have managed to if they've gotten the skill after the training. So after the 1 month internship, that's when we do an assessment, and that assessment will determine whether one can start seeing clients or not. So there's a 1 month internship that happens after the 8 days training. And after the 1 month internship, when the people start seeing clients, the trained participants, when they start seeing clients, that's when they will be offered supervision and refresher trainings. Yeah, just depending on the time of the year. But supervisions and refresher trainings are offered as a form of support.
Thanks, Bernice. What would be the cost driver of implementing this intervention? What are the cost drivers? And then I'll come back to Lambda. I see you still have your hand up, or is an all hand? But Bernice, if you can just share briefly some of the cost drivers for this intervention.
Okay, Humphrey, can you expand a bit on that?
Like, what are the costs of implementing the program? Do you charge for training? If we needed to start it up in another country, for example, Mozambique is interested, what should they be budgeting for exactly? Not necessarily amounts, but what are the things that should prioritize to have in place?
Okay, yes, there is a cost. There is a cost to the training and support. So, but I cannot go into details on that. Yeah, I don't really know it offhand because that's not what I do. So you can send me an email on bernice.chawira@friendshipbench.io. I'll put it in the chat box so that I can refer you to the relevant people.
So again, Stambile, if you can clarify on the chat, we have a question. How are the peer educators and friendship buddies paid? Are they paid, or is this voluntary work? And is there a development pathway, career development pathway of some sorts?
All right, thank you very much for the question. So peer educators, or we have microplanners, we no longer have peer educators, and friendship bench buddies are on a voluntary basis. However, they do get allowances to support their work, as they need to travel sometimes to the facility where they're going to be sitting on the bench, or whether they're offering services. So there are those costs that are associated. They also get data support, is they use tablets to collect data, and they'll need to sync it. So they get an allowance and data support, but they are volunteers. They are not employees of the organization. And then there was a question, I think, about what if a KP does not want to access mental health services from their peer. They have an option of accessing services from the clinicians at the facility or at the DIC center.
So we will take this one last question from Lambda and move on to the next session of our Link and Learn. Over to you. Or is this an old hand? So thank you so much, colleagues, for a wonderful Link and Learn session. In this part of this conversation, we want to have some key takeaways. And I want to hear from Cote d'Ivoire, from Malawi, and from Mozambique representatives on what is it that we learned today. What is it that we are taking away from the conversation that has been shared by Friendship Bench, and also the adaptation of the sex work of the Friendship Bench model for key populations, and particularly for sex work, for MSM, and for trans and gender diverse persons. So I would like to invite Cote d'Ivoire, or there is a hand. Brighton. Please unmute and proceed. Brighton Lopez.
All right. Am I being heard?
Yes,
Allô?
now we can hear you.
Oui, moi je vous entends. Oui, je suis docteur Rabé de la Côte d'Ivoire. Allô? Je suis docteur Rabé de la Côte d'Ivoire. Oui,
Wonderful,
allô?
welcome.
Je suis docteur Rabé de la Côte. Vous m'entendez?
Can I
Allô?
continue?
Yes, we can hear you loud and clear. Please proceed.
All right.
Oui, on vous
No,
entend.
thank you so much for the wonderful presentation. I think I'll speak from Malawi. Blyden, I'm from Malawi. I think mental health is one of the areas that has been less explored, and we feel like mental health has been expensive to somehow, like you shared in the presentation about the psychiatrists. Same here in Malawi, we face the same challenges. But I feel like the mental friend bench model of approach, differentiated model of approach, it may be a solution to screen more and offer support to mental health problems. More likely, like you share that with model French benchmark model, it may help to alleviate or lessen the problem of depression from mild to moderate. So, which is a good progress. I think you can do better. I wish we can adopt in many of our operating sites where we work with key populations. So I think it has been a very good approach for this one, and it has been so enlightening. Thank you so much. That was just my comment.
Thanks a lot, Brighton. If we can hear from Côte d'Ivoire.
Allô? Merci à vous. Je suis donc le docteur Rabé et vraiment, j'ai été émerveillé par cette approche et Friendship Bench qui va permettre de booster les activités de santé mentale en direction des populations clés et que c'est un modèle. Puisque nous aussi, en Côte d'Ivoire, nous avons un programme de santé mentale, mais les psychiatres ne sont pas nombreux, les centres spécialisés ne sont pas nombreux. Et donc, cette approche qui utilise les populations clés elles-mêmes et qui bénéficient d'une formation, je pense que ça pourrait améliorer la santé mentale qui, pour nous, est un moteur essentiel pour la qualité de vie de ces populations clés-là. Et ça permettrait aussi, avec votre approche en ligne, pour atteindre ces populations clés qui sont difficilement accessibles. Et donc, nous avons beaucoup appris. Moi, particulièrement, j'ai été émerveillé que cette approche existe et que on parle d'une évaluation à 3 niveaux et après, il y a des stages avant de commencer à rencontrer la population. Je pense que c'est une bonne approche et ça permettrait d'améliorer les données communautaires au niveau de ces populations clés-là. Et ça va vraiment impacter les activités au sein de ces populations. Donc, moi, mon pays est partant pour que ce modèle-là puisse être implémenté. On pourra commencer un peu progressivement, peut-être avec deux associations, 3, mais vraiment, nous sommes très excités à pouvoir implémenter ça dans notre pays. Vraiment, je vous remercie et que bonne continuation à vous. Merci à SSLN. Merci à vous tous. Merci.
Thanks, Dr. Rabin. We're excited to hear that there's excitement in Côte d'Ivoire to explore and implement the friendship bench. Can we hear from Mozambique colleagues?
Muito obrigado. Meu nome é Antônio Timbano. Venho em nome do Conselho Nacional de Combate ao SIDA, a Unidade Técnica de Suporte às Populações. As duas apresentações foram bastante interessantes para nós e é um modelo inovador. Nunca tínhamos este modelo. Por isso, gostaríamos de congratular estas apresentações que aqui tivemos hoje. Achei interessante, primeiro, o fato de poderem focalizar a primeira apresentação do Friendship Bench Model, que focaliza a questão de pessoas da terceira idade, nós chamamos de terceira idade, grande parte são avós. É interessante perceber como é que a organização conseguiu trabalhar com este grupo e ter uma boa interação com o Ministério da Saúde, daí que estes grupos também foram identificados lá. E dizer que a questão da depressão é também uma questão muito importante quando falamos da população-chave. Como sabemos, questões que têm a ver com estigma e discriminação têm sido o elemento-chave para termos problemas de saúde mental. Por isso que achamos interessante e também gostaríamos de continuar a interagir com as duas organizações, particularmente esta que trabalha com população-chave, nos modelos que têm usado para poderem trabalhar com educadores de pares, com os conselheiros leigos, e como é que nós podemos adotar esta metodologia, pois pode ajudar bastante nas sessões de sensibilização junto dos pares, das populações-chave, relativamente a questões que têm a ver com a depressão e, acima de tudo, a questão do estigma e discriminação. Por isso que, para nós, é uma estratégia inovadora e gostaríamos de poder aprofundar e aplicar junto dos nossos educadores de pares, conselheiros leigos, porque essa questão da saúde mental é crucial para as populações-chave, tendo em conta toda esta dinâmica que estamos sempre a discutir à volta do estigma e discriminação, que é bastante assente nas populações-chave. Então, se conseguirmos trabalhar para eliminar ou reduzir as questões que têm a ver com a depressão, é um elemento bastante chave que pode nos ajudar bastante. Então, gostei muito das apresentações e também acho que é um modelo inovador, é interessante, que nós também gostaríamos de criar estas sinergias com estas organizações que estão a implementar este modelo no Zimbábue, para podermos aprofundar mais junto dos nossos parceiros aqui em Moçambique, como, por exemplo, a Lambda, que esteve aqui a fazer algumas questões para podermos integrar nos nossos pacotes de formação. E muito obrigado.
Thanks a lot, colleagues. This brings us to the end of our session. I'm excited to say we started at about 65 colleagues who joined this call. We are ending this call with a whopping 67 people who are on the call. It means that this is an exciting topic and an area of work that is critically important. Just today in Zimbabwe, we were planning with PEPFAR around what our priorities as key populations for the next coming year would look like. And we discussed a lot around HIV and non-communicable diseases. So mental illness is priority of the issues that we need to be looking into, issues related to aging, to loneliness amongst our key populations, to loss of gainful income amongst our key populations as they age, the reduction in family and social support structures as people age. So it is very important, and we're seeing a lot of hypertension and other cardiovascular diseases in these communities. So it is very important that we look beyond just, PLHIV and preventing HIV, and broaden the scope of our work in seeing how our communities are affected by NCDs. And really, we are open to continued nuancing of this linking and learning. The SSLN has shared already a profile of some of the link and learn opportunities that we have, and we will be visiting this topic around integrating mental health for key populations. But before you knock off, we are kindly requesting that you respond to these few questions that will help us better tailor our learning and our priorities for what we need to be doing next time to ensure that we have a smoother and a more active learning experience. So kindly, if you can complete this poll here, and we wish you a very good afternoon, and thank you so much for taking your time to join this call.